Okay. Good evening. Thank you for coming out today. I know we had quite tragic events yesterday, and we weren't sure how that would impact people coming out today. So what we're going to talk about tonight is something that's also something that's of great concern, I think, to our area, to Ontario, to Canada. And I think we've all heard about the prescription opioid problem, but tonight you're going to hear a little bit particularly about how this is affecting women as a special population. So we're going to start out by talking in general about what's the current state of prescription opioid problems in Ontario. We're going to talk about opioid use, abuse, and dependence as it applies to women and parenting. Talk about some particular risk factors that are relevant, particularly to women, with a focus on mental health problems. We'll talk about some of the treatment options to help women who struggle with opioid problems, and also talk about reducing the stigma and myths regarding women and opioid use problems. So as I mentioned, prescription opioid issues are a huge problem in Canada, throughout the world, and depending on which particular way they slice it, Canada is either #1 or #2 as far as consumer of opioids, and our competitor is the United States. And this isn't really a competition that we really want to win. Ontario, of all the provinces, Ontario unfortunately is at the top, so we're right kind of in the center of the issue. I don't think, you frequently will look at the paper and see articles about overdoses, about problems with prescribing, and it just goes on and on. It doesn't seem to be going away. And when we're talking about opioids, really what seems to be the problem right now is prescription opioids, as opposed to what we call illicit opioids like heroin. And here at the Royal, in the Substance Use and Concurrent Disorders Program, in the last 10 years, we've really seen a huge increase in the number of people who are presenting with a primary concern of prescription opioid dependence or abuse. And the other unfortunate thing about this is that opioids have really become a favorite of young people and young adults. And we'll show some stats on that and why that's concerning. We don't have exact numbers on how big the problem is. There was a study that was done in 2006 that kind of estimated how many people they thought perhaps had a problem with opioids, and they estimated maybe 30,000 in Ontario and maybe 80,000 in Canada. In 2013, we had about 39,000 people registered that were taking methadone on a daily basis, which means those individuals definitely had an opioid problem. We had additional individuals who were taking Suboxone on a daily basis, and then probably at least an equal amount of people who are receiving no treatment at all. This is a study that's done by the Centre of Addiction and Mental Health in Toronto, another psychiatric hospital. And this is a study that's done on Ontario high school students. And this study is done every 2 years to track trends and patterns of what young people are using and abusing. And it's important to know that these numbers do not represent addiction. This represents use, okay? And if you look at the opioid pain relievers, NM stands for non-medicinal use, which basically means this was not a prescription. This was something that somebody used in order to get high. And if you look at these numbers, you'll notice a couple of things. First of all, the males and the females, the percentage is pretty similar. You'll also notice that young people are more likely to actually try an opioid than to actually try a cigarette, which seems quite shocking. In grade 7 and 8, you'll see that that people are experimenting with opioids more so than cannabis. As you get into the older grades, cannabis takes over, but in the younger grades, it's prescription opioids. And I think all of us can remember when we were in high school. For some of us, that's a little bit longer ago than others. But when we were in high school, that's a time when people experiment. And we kind of expect that. And many people go through that experimentation and nothing really happens. The problem with opioids is that experimentation can rapidly lead to addiction and lead to other drug use, and sometimes lead to accidental deaths or overdose. I'm just going to back up a little bit and go through a few definitions so we just make sure that we're kind of all on the same page and we all kind of have the same knowledge. We keep throwing this word out, opioid, and what does that mean exactly? So first of all, opioids, we classify them as depressants. And other common substances that we would classify as depressants would be things like alcohol, or a benzodiazepine, something like Ativan or clonazepam. And basically what these have in common is they tend to slow the body down. Opioids are sometimes referred to as narcotics. They can be quite effective painkillers. And opioids can either be prescription medications or they can be illicit drugs such as heroin. Kind of our top three at the present time, oxycodone, fentanyl, and dilaudid or hydromorph. Oxycodone kind of is probably the thing that kind of started it all 10 or 15 years ago, where people really started to be exposed to high doses of opioids. They changed the formulation to make it less abusable, and then some generics have come along. So it's still certainly used. It's probably not the most popular at this moment, just because it's not probably quite as available. Dilaudid or hydromorph is probably one of the more popular ones right now. And then the fentanyl patches that are a particular concern because first of all, they're very potent. They're felt to be about 80 to 100 times stronger than morphine, and you don't necessarily know how much you're getting out of that particular piece of the drug that you're using. And what these all have in common is that people basically alter the way that they're supposed to be taken in order to get a large amount of the drug in a short period of time. So what's the big deal with misusing or using an opioid? I guess probably the most concerning thing, or the most concerning immediate thing, especially for those new users, is overdose. When you don't have tolerance, your respiration can be affected by consuming opioids, and you can end up not waking up. If you don't know the dose, in the case of fentanyl, and then if you combine it with other things, young people often drink alcohol, and if you combine that with an opioid, that's going to increase your risk. The other thing is, after people stop using opioids, so say they choose to stop or they detox, during that particular time, if they relapse, they've lost some of their tolerance and they can overdose. The worst case scenario from an overdose obviously is death. We see accidents, addiction, and then we can see infections just depending on the way that the person uses the substance, things like hepatitis C or HIV. As far as why did this become a problem, why is this a problem right now, I think there's a whole group of individuals that never would have tried heroin. There's a whole group of our society that's been exposed to a drug that we never would have normally been exposed to. And because it's a prescription, because it's made by a pharmaceutical company, because we get it from a doctor, we see it as being safe. And we might even think it's safe to give to one of our friends or give to one of our relatives if they're having a pain or something like that. It's pure, it's very strong, easy to access, and when you start altering it, then it becomes a very powerful addictive drug. I'm happy to say we do have drug monitoring now in Ontario, but it was very slow to come. And I think that's part of why things got a little bit out of control. Now, when you go to fill a prescription, you have to present identification, and it goes into a database. And if you've filled a prescription from more than one doctor, or are going to more than one pharmacy, or things don't add up, it'll be flagged in the system, and you won't get your prescription. And I think it's also important that we don't demonize opioids, because we do need to have painkillers available for certain conditions. So I don't think we can say that opioids are all bad. And there are some people who take their medications properly. There's some people that have a bigger benefit from taking the medication than side effects. And even if you take an opioid as prescribed, if you were to stop it suddenly, you would experience withdrawal symptoms. That would be normal. And that doesn't mean that the person is what we would call addicted. And sometimes people misinterpret that, or family members misinterpret that and think, well, when they stop it, they have withdrawal symptoms, so therefore they must be addicted. So we'll just talk about what is addiction. And addiction, for the most part, actually starts in adolescence, that time when we're experimenting and connecting with different substances. This is a definition from the American Society of Addiction Medicine, and they define addiction as a primary chronic disease, and I want to point that out, disease of the brain, reward, motivation, memory, and related circuitry. And it's characterized by an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. So it's a disease of the brain. It affects some of the areas that help us to make decisions. And I think that's part of what sometimes can be very frustrating with family members that are coping with somebody who has an addiction, is trying to understand why do they keep doing this. Like other chronic diseases, it's common that there's relapses and remissions, and addiction can be progressive and can result in disability or premature death. So that's our definition of addiction. Again, so we're just kind of all on the same page. So it causes problems. If we look at, if we think about substance use and we kind of look back, I think in general it's often been thought of as a disease that mostly men have. And that has really been changing. In the last 10 years, if you look at studies, and this has been replicated in multiple different studies, we start to see that young women and young men are using substances at the same rate, that their patterns of drug use are similar, and we really all of a sudden see a shrinking gender gap, especially in the young age group. You can see on this graph, looking at, this is past year abuse or dependence on alcohol or any illicit drug. So it's lumped alcohol and illicit drugs together by gender and age. In the 12 to 17-year-old group, it's actually equal between men and women. You start to see a bit of a gap as you get 18 and older, and that's really 18 to 65. So that's a large group. The other thing you'll see really in both men and women is that your highest rates of abuse and dependence are always in the youngest age group. So in this, again, you can see in the 18 to 25, you're seeing this much larger percentage of people who have a problem compared to in the age group of 50 or older. This shows what's currently going on in regards to methadone, and methadone is a treatment for opioid dependence. And so when we look at these numbers, it gives us some idea perhaps of how many people have an opioid dependence and what that division looks like, and what's the difference between men and women. And this is data from 2013 from Ontario. And in the 17 to 21-year-old age group, there's actually more young women who are on methadone maintenance than men. In the 22 to 25, the men start to surpass, and as we go up to the higher age groups, the men greatly surpass. I think it would be helpful for us just to kind of take a moment and hear a little bit from women themselves about what it's like to be a woman who's struggling with a substance use problem.
As a woman, you just don't want people to look at you like that. You're a mom. You don't want to admit it. You don't want your kids to know. Because you think they don't know, but they know. I
started having a glass of wine with dinner, and then I'd have a couple of glasses before I went to bed, and then the next thing I knew, it was a couple of years later, and it was quite out of control. And I didn't want to face it, but it reached the point where I couldn't stop. I was drinking every day.
A woman has more shame and guilt, shame of physical, sexual abuse. You don't have the resources, babysitters, you've got the schools looking at you differently. You're supposed to be the role model more so than a man.
My time. It was for me. And I didn't allow anyone else to interfere. Phones went off, kids were out. I went in my room if they weren't out. It was me. And I used the excuse I needed that time to get through the next week.
From a family that did all of the right things, and
it's when people are gambling, right? I've got $500 in my pocket right now, but $450 of that is the rent money.
It was only in the mid-1990s that researchers began to pay attention to the profoundly powerful differences between the substance abuse experiences of men and women.
Obviously, men and women metabolize things differently, whether it's alcohol or drugs. And I think there's this social stigma of, you gotta keep up with the boys. Drink for drink, shot for shot. But then all of a sudden the girls passed out on the floor, getting sick. And the men are all like, oh, laughing at her or treating her differently.
I went through a period where I was having to take heavy narcotics for pain.
I ended up having some major prescription drug problems. Ended up trouble with the law.
2 jobs, losing our house, losing a car, getting pregnant when you didn't want to, having to leave.
And when I went through detox to get off the drugs because I couldn't get off them myself.
People and young people grow up in these communities that's what they do for fun. That's how
I suffer from depression as well.
Wants a piece of me all the time, but I can go and sit in front of the machines. The machines don't want anything from me. Gambling does the same thing. Just sets into motion the same addictive pathways so that you'll be on the machines for a while and then you'll be at home and you're like, how am I going to get to the machine? Where am I going to get the money? When am I going to get there next? Like, you're just consumed with the idea of going back.
I didn't come from a family like that, and I want more for my children.
One spring morning in Nova Scotia's Annapolis Valley, 136 women and 4 men gathered to use their influence to reduce stigma and break down stereotypes, to share stories of when they had been at their best, living and working with rural women affected by substance abuse, gambling, and violence. They came to hear their voices and heal their communities.
That everybody has a voice. Everybody has the ability to stand up and, say, I'm a person. I'm not that addiction. I'm not, the little girl that was hurt as a child or abused, or that, you know, they're more than that.
When you feel safe enough to offer yourself to others, in whatever capacity you feel it is you have, you're a great typist, you're a painter, you're a great flower arranger, you make great pies, make excellent soup, whatever it is, and you hear the call of something in their community, and you decide that what you have to offer is worth offering, you do so much more than you think you're doing. By being honest with oneself and feeling things deeply, you can't help but touch others.
If I had a magic wand, I would make it so that my children did not have to suffer through anything that I did. And I think that that would happen through education and awareness and older people that can be good examples and motivate them, inspire them to want to be more. Yeah, that's pretty simple.
Hi. I think that's just an excellent opportunity to actually hear from the women who themselves have struggled, and some who are in recovery and at different stages of where they're at, to hear what it's like for their experiences from a variety of addictions. And I think they can say things in a way that we really can't express up here through slides and education, and to actually be able to hear from the people who struggle themselves. So we're going to focus a little bit more, as Dr. Willows was talking about. She was mentioning that the gender gap is narrowing in terms of addiction, and we now see, especially in the young age group, more women, as many women struggling with addiction problems as men. And the same is actually true for opioid misuse, but even at a higher rate. In fact, rates of non-medicinal, so that means using prescription opioids for a non-medical reason, is actually higher among women than men, particularly for opioids. And when we say this, most people are actually quite surprised by that, because still when people think of addiction, they think it's a man's disease, much like when they think of cardiac illness, they think it's a man's disease. And that's certainly not the case, and specifically not for opioid use problems. In fact, nearly 48,000 women died of prescription opioid overdoses between 1999 and 2010, and that's actually a 5-fold increase of women dying from prescription opioid overdoses in 2010. And when we compare that to men, female deaths have actually increased by 400% in that time period, while men's have increased by 265% during that period. So this is a graph that actually looks at prescription opioid, they call it painkiller, but they mean opioids, overdose deaths from the period of 1999 until 2010. And if you look at the bottom red line, this is heroin, and as Dr. Willows was talking about, there's different types of opioids, the prescription opioids and the illicit opioids. So heroin was that illicit opioid she was talking about. And then if you look at these that cluster in between here, there are other types of prescription, there's cocaine as well as benzodiazepines and antidepressants. And if you look at this purple line, that's the opioid line. So if you look, this is the number of overdose deaths in 1999 for women, and over here, that's the number of deaths by 2010, showing you that 400% increase in that 10-year time period. Overdose deaths is an issue as well. For every woman who dies of prescription overdose, 30 go to the ER because of the prescription opioid misuse or abuse.
People often ask, especially family members, where are people getting these substances from? Where are they getting their substances from? So if you look here, the majority of people, especially young people, are getting their prescription opioids from family members, but most people are actually getting them from friends and relatives, and then the vast majority of those drugs are actually this red box over here, coming from where the friend or relative are obtaining them from is usually one physician. So why are women more disproportionately affected by the prescription opioid problem? And I think there's several reasons, and they have to do with what women have more likelihood of having to begin with. So in general, women are actually more likely to report chronic pain, and they're more likely to seek treatment for their chronic pain than men. And when they seek treatment from their physicians, they're actually more likely to be prescribed a prescription opioid than men are. Not only are they more likely to prescribe a prescription opioid, they're actually more likely to be given higher doses. Not only are they more likely to be given higher doses, they're more likely to be given them for a longer period of time. When you couple that together with the fact that women are actually more likely to become dependent quicker to prescription opioids than men, you can actually see where this problem has come from. And we'll talk a little bit about the last point in a couple minutes. So I thought we'd turn a little bit to the risk factors. I think to understand opioid addiction in women, we really have to understand many things. We have to understand the socio-cultural context with women live in. We have to understand their different mental health issues than men. We have to understand the different trauma experiences that they've had to get a true understanding of why it is that women are struggling to this degree with this problem. So when we look at risk factors, we kind of separate them out into a number of factors that end up leading to addiction. And the first is a vulnerable host. So that's this one here over here. So by vulnerable host, we mean women's or anyone's for addiction. Psychological or physical, biological, genetic predisposition that would make them vulnerable to addiction to begin with. The second has to do with the environmental and sociocultural context. So where we live, as Dr. Willows was talking about in the case of opioids, why are they more popular right now? Why is that a drug of choice? And she went through many of those reasons. And a lot of those had to do with the context of either availability, of where you're living and who your friend groups are, and for women it could be the experiences they've had as children and growing up as well. And then the final one is repeated substance use, and Dr. Willows talked a bit about how that develops into addiction. So across the board, one of the key risk factors for women to develop substance use problems are actually relationships. And when you talk to most women, the thing that they'll often report are most important in their world are their relationships. And it is these relationships in some of these women that are actually for some part, are able to predict their likelihood of having substance use problems. So when we look at women compared to men, women are actually more likely to be introduced to and initiate drug use through their boyfriends, partners, spouses, and relatives. In fact, if you look at first IV drug use, 51% of women are 51% of women, when we look at some stats out there, are actually first injected by their male partner. When you look at men, 90% of men are actually first injected by a friend. So even though women are less likely to inject drugs than men, women actually accelerate to injecting at a faster rate than men. And in addition, what's more very concerning in the population is that women are actually more likely to inject with and borrow needles and other drug equipment from their partners. So here's why that's concerning. Remember we talked about some of the risks of opioid addiction are actually HIV and Hep C. Well, one of the key means of transmission of HIV and Hep C is through sharing drug equipment, needles, and other paraphernalia. If you started your using as a woman by being injected by a male partner who likely is part of, is using by IV drugs himself, then you could see how sharing that equipment with him or other people really puts them at an increased likelihood potentially of contracting HIV and hepatitis C. And this is why, in addition to the addiction problems, in addition to the mental health problems, this is why this becomes a real public health issue. So why are women sharing drug equipment? Why are they in this position with men? Well, people's initial response when you tell them is, well, why are they with these men anyway? Can't they just leave? Why do they choose these men? Why do they stay? Well, let's think about how they got there to begin with. Remember I said most of them started by being injected by a male who's often someone of some significance in their life. They may actually see their sharing of drug equipment or using other drugs with this male partner as a form of intimacy, connection, or maintaining the relationships. But moreover, the problem is in these relationships, men are often the ones who are responsible for obtaining the drugs, purchasing the drug, and injecting the women with drugs. So now the woman's supply, or their source, that often continues the cycle of addiction is the men who keep them in that position. So there's a huge power imbalance in women who are struggling with IV drug use, especially those, and this is why relationships really are defining often women's drug use initiation cycles and their maintenance. Remember I mentioned before that women are actually more likely to progress to dependence at a faster rate than men? Well, this is actually found in many substances, including opioids, and it's a principle we call telescoping. And it really talks about the accelerated progression from time of first use to the onset of dependence and first treatment. And consistently observed across studies, we see women telescope or have this accelerated progression at a faster rate than men. What's really interesting is women will telescope or accelerate faster from the time of first use to the time of dependence, even when using similar or lesser amounts of drugs than their male counterpart. So that means when they enter treatment, they're actually present in a more severe picture than men do, despite the fact that they may have been using less drugs and for a shorter period of time. Another key factor is trauma as a risk factor for women. The initiation of substance use, the development of substance use disorder has a strong correlation and connection to traumatic events. Things like, and by traumas, I mean childhood traumas, either suffering from physical or sexual abuse, interpersonal violence, sexual assault, rapes, abusive relationships. Often these partners who are supplying their drugs, that the interpersonal violence in those relationships, as well as domestic violence. This is a reality for many of the women who are struggling with these problems. So what are the rates of physical and sexual abuse in this group of women? Depending on what study you look at, 55 to 95% of women have suffered physical or sexual abuse who have substance use disorders. And what's interesting is the severity of their substance use disorder can be directly mapped or correlated with the number of violence assaults they experience. That means the higher number of assaults they've experienced, the more severe their substance use problem, vice versa. Among women seeking treatment for substance use, about 70% actually report sexual abuse prior to the age of 11 years old. The thing about violence, and it was talked about in that video a bit, that becomes the experience, for many of these women, a real cycle. If you look at 70% before 11, if that is what they knew as children, that is what formed their attachments and their relationships and defined who they were. And then that predicts their likelihood of having a substance use problem. And women who have substance use problems are more likely to suffer violence and as an effect of the substance use or because of some of the lifestyle that may go along with using substances. That means they're in this cycle of violence from the time they were young people. And the substance use actually increases their vulnerability to this violence, and unfortunately, from starting as trauma to being re-traumatized and re-victimized as a result of their substance use. Another risk factor is mental health disorders. So in general, compared to men, women have a higher prevalence of mental health, concurrent mental health problems when we look at things like anxiety and mood disorders. About 2/3 of women, that's 66% of women with a substance use problem, have a co-occurring mental health problem. Women are more likely to use substances to manage their negative affects, so feelings of stress, feelings of low mood, feelings of anxiety, feeling the trauma experiences. Their trauma history and PTSD, many women will report that they use substances just not to feel anymore, so they just don't have to think about those times. And mental illness is both a risk factor and a consequence of substance use problems, such that people who have mental health problems are more likely to have substance use problems, and people who have substance use problems are more likely to develop mental health problems. The rates of mood and anxiety disorders in the population is about 30% in the last 12 months. That would mean 30% of women with a substance use problem have experienced either a major depressive episode or an anxiety problem, bipolar disorder. And eating disorders is another huge issue in this population. Again, like mental health problems such as anxiety and depression, which are more common in women, eating disorders are by far more common in women than men. About 90% of cases of anorexia and bulimia are found in women. And there's a high correlation between eating disorders and substance abuse, with up to 55% of women who have bulimia having a substance use problem. Another big issue is discrimination. We talk about the stigma from substance use, which leads to many negative experiences for these women. If any of you know of or have a friend or a family member or work with women like this, they can tell you countless stories of not being able to get the help they need because they were either pregnant with the substance use problem or had children and have a substance use problem. And people are very good at giving them all the reasons why they're really bad women and really bad mothers and really bad wives, and not really trying to figure out how they can offer them help. But in addition to struggling with the stigma from their substance use problem, they're struggling from multiple other forms of discrimination related to mental illness. As I said, they have higher rates of mental illness, and specifically when they have substance use problems. Issues related to their age, social economic status. It's well known that women have lower incomes and lower levels of social economic status than men. Issues related to their housing, their race, ethnicity, language. There's multiple levels of discrimination that women face, and those all interact together to make it even more stigmatizing, and we end up with this problem of compounded stigma in women who are basically trying to get help, and from reason of their substance use problem, mental health problems, plus all these problems up here, they're less likely to actually be helped because of that. So because of all these reasons, despite having accelerated progression to dependence, despite knowing that we have equal rates of substance use problems in men and women, especially in the young groups, women are vastly underrepresented in substance use treatment. So even where you'd expect in some of these situations to see 50% or 60%, or in prescription opioids even more than that, of the people be women, you don't even see half of that in some of these, instead of the studies that you look at. And part of that is because women are less likely to enter treatment. They actually tend to seek care in primary care settings rather than going to specialized substance use treatment programs. However, despite this, once initiated, so if we can actually engage women, meet them where they're at, and help them get into treatment, they're actually more likely than men to adhere to treatment and stay in. And you would think with all of this, women would be more likely to drop out, that they wouldn't come, that they wouldn't get better. That's actually not the case. There doesn't seem to me much gender differences, if treated in the right environment, between women and men's outcome for substance use treatment. So we talked a bit about the barriers, but Health Canada actually looked at recognizing the problem in women, recognizing their underrepresentation, about what are some of the things we can do to make treatment more accessible and acceptable and available to these women so they can get the help they need. So what they did was they started by looking at, why aren't women going to treatment? And I wish I would have asked instead of put the slide up first, but the number one reason really is their children. There's significant consequences that women can potentially suffer by admitting they have a substance use problem and seeking help. In fact, in some states, it's criminal offense. So in terms of having a substance use problem with young children, you can actually be potentially in part of the legal system because of that. That's probably not going to make a lot of women go get help. So you fear losing your kids. Even if you don't fear losing your kids, you have to sometimes go away for treatment, or even if you have to go to a day treatment, even if you have to go to an appointment, and if you don't have a lot of money, where are you going to get your child care? Where are you going to put them while you have to go for treatment? So remember, relationships are very important to women. And if they're the ones who primarily have their children, where are they going to go? Lack of family support, There's social stigma, which I talked about. There's a lack of women-centered services. I think we use a one-size-fits-all approach in a lot of treatment programs, and we don't really recognize the gender differences between men and women, and we paint everybody with the same brush, and we're like, this is what we got to offer. Take it or leave it. Sometimes treatments have cost, of course, not all of them, and most of the ones we have here don't. And there's lack of flexibility in services. The other big reason that women don't get treatment, again back to relationships, is partner substance abuse. Let's think about it. So your partner's the one who helps get you addicted. He continues to maintain you on your drugs by purchasing them and providing them for you. How keen is he going to be for you to go into treatment? Probably not so much. There's low rates for identification and referral for women by healthcare providers. And I think part of this is because we don't view substance use with a gender lens. It's like back in the days when we talked about cardiac disease, when everybody thought that was a men's illness. Women were dying of heart attacks more because they weren't even getting identified that they had a cardiac problem. It's the same thing that we see in substance use issues. Lack of transportation, being a caretaker role of the family. If you're the one responsible for those kids, who's going to take care of them? Are you going to leave them with that partner? So I think this leads, again, we talked about one of the things we want to talk about, what we tried to put through this, the whole presentation here, was the issue of stigma. It is very well known that there is more stigma toward women who abuse substances than men. Through frontline healthcare workers, ER departments, family members, friends, people at the grocery store, general community, you choose it, women are stigmatized more, likely because of the fact that they have children or are pregnant at the time. And we know that if you put women in a situation where they don't feel safe, where they're going to feel judged, heck, not even women, anybody, you put anyone in a situation where they don't feel safe, they're going to feel judged, they're going to feel that there's going to be threats of legal sanction, how likely are they to go seek help? So the societal stigma and the stigma that healthcare workers act as a barrier for women to actually seek and initiate treatment to get the help that they need and deserve. And this stigma and the guilt that society gives to women often becomes internalized by these women, and that becomes part of their own personal lens with how they look at themselves, which leads them to feeling guilty and shameful. And people who feel guilty and shameful and stigmatized against themselves don't feel like they even deserve the help that even could be available to them. So I keep going back to relationships and caregiving, but the fact that women are socialized to be other-focused and assume caregiver roles makes it very difficult for them to say, you know what, I'm just going to forget about it and think about myself. So what can we do about this? Because frankly, it paints a pretty grim picture when you kind of look at it, but it's not a grim picture. In fact, we know if we pay some attention to the fact that there are gender issues in substance use, and that these gender differences affect society's view of women, it affects treatment engagement, it affects treatment outcome. If we understand that and do something to break down those barriers, we can engage more women in treatment, and we know if we can engage women in treatment, they can do well, or even better than their male counterparts that the treatment was designed for, as long as we're responsive and appropriate and have things tailored for women who are different than men are. So there's a lot of work done by SAMHSA, which is an American organization for mental health and substance abuse, on how do we best have to respond to women. And from when I've shown you a lot of the risk factors, this isn't something that can be managed just within a treatment center itself, because the risk factors and the outcomes and the consequences and what we know will help women get better is a societal response. So yes, we need the center of this basket, clinical treatment services that are gender sensitive, for women, by women, to meet their needs and help them with managing their children and help them with parenting and pregnancy and the caregiving roles and their relationships and the things that are important for women that we know if we help them with can help them help themselves. But in addition to that, we need to have clinical support services and community services, housing, education, childcare, transportation, financial supports that help women. Because some of those key barriers to get women to treatment actually the treatment programs themselves, but was the rest of the stuff that's going on that acts as a barrier. And this basket of interwoven and interdependent circles recognized with that gender lens. So when we look at core principles of gender responsive treatment that we know have given women really good outcome, it's really, the key part of all those was recognizing the role and significance of women's relationships in their lives. Often when women enter into treatment or they come to talk to somebody, the answer is, well, maybe you need to be away from your kids right now, or just leave your partner and have nothing to do with them, and your caregiving role is getting in the way, how are you going to care for yourself? That's actually not very helpful, because that's what's important to women. So recognizing the role and significance of those relationships and working with it will help engage more women in treatment and keep them there. Adopting a trauma-informed perspective is very, very important. I showed you the very, very high prevalence rates of childhood trauma as well as current trauma. I don't think I showed you one of the percentages that 60% of women who enter substance use experience trauma currently as an adult, either through sexual assaults or physical assaults, often from partners or other parts of the lifestyle. So adopting a trauma-informed perspective so that we have these women feel safe and not judged, and that we recognize why they are where they are, is very important for treatment. Again, using a strengths-based approach. Focusing on people's weaknesses is a really poor way to help people get better and feel better about themselves. No matter and those women pointed it out. Remember there was that one woman in the video, she said, what is your strength? Was it your children? Was it being a nice friend? Was it being a good artist? I think she even said, can you make good soup? Whatever it is that it is, finding what those strengths are and working from women's strengths. And incorporating an integrated multidisciplinary approach, incorporating mental health care and a variety of disciplines into treatment for women, recognizing their various facets. Therapeutic alliance, which is a fancy word for rapport and collaboration between healthcare workers and women, is a key predictor of treatment. When women feel a sense of acceptance and collaboration as opposed to a top-down power differential, they're more likely to stay in treatment. On-site child care and children's services. Most of the programs talk about not only treating women, but treating women with their children, recognizing the importance of parenting skills and pregnancy issues in women. And a complex, multidisciplinary, multimodal approach, looking at behavioral, psychological, psychosocial, and multiple systems of care, like social services that really affect these women. And as much as we can, having support and participation of significant others. So recognizing women especially are not going to get better in silos because of their relationships and their importance to them. Women are, despite all this, have shown remarkable resilience, and I don't think we can forget that. And those of us who work in this field could probably tell you up-teen stories, recognizing the resilience of women and the experience they've gone through and watching them get on a road to recovery. Women and men actually, despite all this, are equally likely to complete treatment. They have similar treatment outcomes, and in fact, they're actually more likely to do better and less likely to relapse than men are, with better longer-term recovery outcomes as long as they're treated in a way that's focused on gender-oriented approaches. So I like to leave this on a bit of a call to action for those of us who are in the audience who work with the population, or frankly, even if you don't work with this population, if they're your family, if they're your friends, if they're the people you see when you're walking downtown or at your local convenience store, wherever you are, recognizing the importance of reducing discrimination and stigma faced by women, recognizing that substance use is a women's issue. Women have been largely ignored in addictions research, and when something's largely ignored in the research, the problem clinically is treatments aren't designed, effective treatments for them aren't designed. So once more identification is out there, and once this issue comes to the surface, we're more likely to study it, and when we can study something, we're more likely to find effective treatments. So we really need research in the area. And we really need to ensure the programs and the work we do adopt a multidisciplinary approach that's gender responsive. and have a coordinated and integrative system of care. These silos are good for nobody. This isn't specific to women. They really help nobody. And having this integration among the clinical treatment services, the support services, and our community services really will help women that we, a lot of us work hard to try to serve. So I want to leave this just on a few images here of the kind of women that we're working with. So I think we all know who these women are. They're the people we see every day. And I think together we can, we're committed anyway through our program and through our programs here at the Royal and many of our partners we work with to addressing these unique needs to help women live to the potential that they so rightly deserve. Thank you.